Hello. In the ICU, when a patient's kidneys begin to fail, every second counts. Today, we're going to focus on a truly life-saving intervention, continuous renal replacement therapy. We're going to break down the practical aspects of how it works and, more importantly, how you can manage it effectively at the bedside.
Acute kidney injury, or AKI, is much more than just a complication. It's a key driver of mortality in our critically ill patients. The fluid and metabolic chaos it creates can set off a devastating domino effect of multi-organ failure. That's where CRRT comes in. Think of it as a vital bridge providing gentle, non-stop support that buys the patient's body the precious time it needs to recover.
I'm Dr. Mech, and you're listening to the Dr. Mech series, where our goal is to bring you concise, high-yield educational content. The material for today's explainer is based on tutorial 548 from Anesthesia Tutorial of the Week, which provides an excellent framework for the clinical use of CRRT. Now, a quick but very important disclaimer. This content is for educational purposes only. It is not a substitute for medical advice. Please always adhere to your local clinical guidelines and your institution-specific protocols when managing these complex patients. Okay, here's our roadmap. We'll start with the indications, when to even begin therapy. Then we'll get into the nuts and bolts of initiation and the different modalities you can choose from. After that, a really crucial section on anticoagulation, followed by potential complications to watch out for. And we'll wrap up by talking about how to safely stop the therapy.
You are listening to the Dr. Mech series.
All right, our first section, this is all about one of the most important decisions we make, timing. Knowing precisely when to pull the trigger on CRRT is every bit as critical as knowing how to run the machine. So let's review the specific clinical triggers that should put CRRT on your immediate radar.
The indications are generally absolute and life-threatening. We're talking about severe metabolic acidosis, say a pH under 7.1, that isn't responding to bicarb. Or severe hyperkalemia, especially over 6.5 with ECG changes, where you're worried about imminent cardiac arrest. Then, of course, there's symptomatic uremia, causing issues like encephalopathy or pericarditis, and refractory fluid overload, leading to severe pulmonary edema and hypoxia. So, you've made the call to start. The next question is, which modality do you choose? This decision really hinges on what your primary therapeutic goal is for that specific patient.
It boils down to three main choices. First, you've got CVVH, or hemofiltration. This uses convection, which is fantastic for clearing out larger molecules like inflammatory cytokines. You can think of it as giving the blood a thorough rinse. Second is CVVHD, or hemodialysis, which uses diffusion. This is incredibly efficient for removing small solutes like urea and potassium. And finally, there's CVVHDF, which, just as the name implies, combines both methods. So the question you have to ask is, what are we targeting? Inflammation, uremia, or both? Now for what is often the biggest management headache, anticoagulation. Keeping that extracorporeal circuit from clotting is a major challenge. If it clots, you have blood loss, therapy downtime, it's a real problem. So getting the anticoagulation strategy right is absolutely essential.
In many ICUs, regional citrate anticoagulation is now the standard of care. Here's how it works. A citrate solution is infused into the circuit just before the filter. The citrate binds up or chelates ionized calcium, which prevents the clotting cascade from firing inside the circuit. Meanwhile, the patient gets a separate calcium infusion to keep their systemic calcium levels normal. The key here is meticulous, and I mean meticulous monitoring. You're aiming for a post-filter ionized calcium level below about 0.4 to keep the circuit open, while ensuring the patient's systemic level stays right in the normal range.
As you know, any life-sustaining therapy comes with its own set of risks, and CRRT is no exception. Being proactive with your monitoring and having a systematic approach to troubleshooting are absolutely critical for patient safety.
So what do we need to be vigilant for? Well, I find it really helpful to break down the complications into three main buckets: things that can go wrong with the circuit, things that can happen to the patient, and metabolic disturbances that the therapy itself can cause.
First, circuit problems. Filter clotting and vascular access issues are probably the most common. For the patient, you have to be ready for hypotension, particularly when you first initiate therapy. Hemorrhagic from anticoagulation is a real risk, as are catheter-related infections. And finally, on the metabolic side, CRRT can really strip electrolytes. Watch out for hypophosphatemia, hypomagnesemia, and hypokalemia. And if you're using citrate, you need to be on high alert for metabolic alkalosis and sudden shifts in ionized calcium.
You are listening to the Dr. Mech series.
Okay, let's talk about the end goal. Remember, CRRT is supposed to be a temporary support. The ultimate objective is to get the patient off of it. Recognizing the signs of renal recovery and knowing exactly when to stop is a crucial milestone in their recovery.
So how do we know that kidneys are ready to take over? The decision to stop is based on clear evidence of recovery. First, the original reason for starting therapy needs to be resolved. The acidosis is corrected, the electrolytes are stable. But most importantly, you need to see signs of intrinsic kidney function coming back. This means a sustained rise in urine output, usually more than 400 or 500 milliliters a day without diuretics, and an improving creatinine clearance. And of course, the patient needs to be hemodynamically stable enough to tolerate being off the circuit. I hope this structured look at continuous renal replacement therapy has been valuable for your practice. If you found this helpful, please subscribe to the Dr. Mech series and activate notifications so you won't miss our future explainers on critical care medicine. And to close, I'd like to leave you with a thought. CRRT has already evolved from just a replacement therapy to a sophisticated tool for metabolic control. But as our understanding of AKI, especially the role of inflammation and cellular injury, gets deeper, the real question is this: how will these therapies evolve beyond simply replacing kidney function? Could they one day actively modulate the disease process itself? That remains a critical frontier for research and innovation. Thank you.